Hey everyone, Vicky from NP Reasoning here. Today we're going to get into positive and negative predictive values. I promise I will spare you any complicated mathematical formulas. I'm really going to be focusing on clinical application and practical use of negative and positive predictive values. Strongly recommend, if you haven't seen the sensitivity and specificity video, to watch that before, because NPV and PPV will make a bit more sense once you've mastered the concepts of sensitivity and specificity. So, a recap for when we're ordering diagnostic tests, one of the key questions you need to ask yourself before ordering something is, I'm going to order it. If the test comes back positive, what does it mean for this case? Does it make sense? Does it correlate clinically? Second question you'll want to ask is, what will a negative result mean for this case? Is that going to make sense to me? Is it, again, going to clinically correlate to that person that is in front of me? And these questions help you identify the test characteristics. How sensitive is this test? How specific is this test? How accurate is that result going to be? And will it make sense for the clinical scenario? So, what are positive predictive values exactly? Essentially, what it says is, if the test is positive, what is the probability the patient actually has that disease? And the important aspect of negative and positive predictive values is it incorporates disease prevalence into the equation. Sensitivity and specificity specifically just look at the test characteristics, but negative and positive predictive values incorporate disease prevalence, which is key. It incorporates that person in front of us, essentially. What is prevalence again? So, the proportion of people in a population with a disease at a specific point in time. On the flip side, negative predictive value is essentially saying, this test came back negative. What's the probability the patient is actually disease free? And again, it's incorporating disease prevalence, right? How common is this disease, or how rare other diseases are? So let's get into some clinical examples to make these test principles clear. So, first example, let's say a person's presenting to you with fever, severe headaches, diarrhea, vomiting, abdominal pain. Right away, you have a long list of differentials. And let's say you're working out in the Congo in Africa, where prevalence of Ebola is amongst the highest in the world. And there's been a recent outbreak. So part of your differential is going to be asking, all right, what's my pre-test probability for Ebola? Probably moderate, right? Because you're incorporating disease prevalence and the classic features of Ebola, the fever, severe headaches, diarrhea, abdominal pain, etc. So you ask yourself, should I be ordering PCR testing for Ebola? The answer is probably yes, right? Considering where you're working and the presentation and the recent outbreak, and the result is positive. What does this mean? In other words, can I trust that it's a false positive result? Is it a true positive result? Or could this be a false positive? Well, logically, you're thinking, okay, I have a patient presenting to me where prevalence of Ebola is high, they're having classic signs of Ebola, and the test is positive. This clinically makes sense, so I'm going to trust this test result. Polar opposite, let's think about a patient, again, similarly, is presenting with fever, severe headache, diarrhea, vomiting, abdominal pain. But you work in British Columbia in Canada, where prevalence of Ebola is very low. And there's been no recent outbreaks. You're not really concerned about Ebola. But you ask yourself, pretest probability for Ebola right now, very low. Chances are you're not going to be ordering it, right? But let's say for some crazy reason, you order PCR testing for Ebola and the result comes back positive. What does this mean for this case? Right? So essentially, it's incorporating, again, disease prevalence of Ebola is very low. Your pretest probability is low. Sure, they're presenting with symptoms that could be aligned with Ebola, but chances are I'm not going to trust this test result. Just because it's positive doesn't mean that it's a true positive. In fact, it's probably a false positive, right? It's not clinically correlating with my case. So here's a classic example, right? This is a bit of an extreme example, but it just stipulates that clear and structured approach to when we're ordering tests is, what am I going to do with the positive result? What am I going to do with the negative result? Is this test the most appropriate to order based on my pretest probability of disease? Right? That's all positive and negative predictive values are. They take into consideration the symptoms of disease, that patient in front of you, disease prevalence, and the test characteristics. So it really ties it up nicely for us in a bow. Now let's get into negative predictive values. Again, two pretty extreme examples to really illustrate what these testing principles mean. So let's say a patient's coming to you for TB skin testing. It's required for a healthcare job, which is common, right, for us. No major risk factors for TB, like exposure to sick contacts, recent travel to a TB endemic country, etc. They reside in London, Ontario, where you also work. Yeah, of course, your pretest probability for TB is low. We know we're just doing it for a screening. And you go ahead and perform the skin test. The result's negative. What does this mean? Well, again, right? We ask why the test was ordered. It was for screening. We ask, does this person have any risk factors for TB? No. Do they have any symptoms of TB? Let's say no. And that result is negative. So we're asking ourselves, can this be trusted? Is this a true negative or is it a false negative? Does it correlate clinically to that person that I saw? So the question is, yeah, the answer is, yeah, we can trust that this result is negative, because it makes sense with the case in front of us. It makes sense why we ordered the test. We can trust that it's a true negative. Polar opposite kind of extreme example. Let's say a person's presenting with cough, fever, night sweats. They're coughing up blood. They reside in Nunavut, up northern Canada, where you also work. Your pretest probability for TB as part of your differentials is at least moderate to high. And we know logistically for this kind of case, we would be ordering chest x-ray, sputum samples, arranging urgent investigations. But let's say in some extreme example, right, you order TB skin testing, which would not be the appropriate workup. Let's say you do order it for some reason, and the result is negative. Again, does that make any sense to us? Absolutely not, right? We still have that moderate to high pretest probability that this person has active tuberculosis. Just because that TB skin test was negative doesn't mean that it correlates clinically with that person in front of us. This is likely a false negative, right? So, again, with negative and positive predictive values, we are incorporating number one, the test characteristics, sensitivity, and specificity. But number two, we're taking into account disease prevalence and our pretest probability, of course, right? Is this low, medium, or high? Does this test result correlate or clinically correlate with that person in front of us? You have to ask yourself these questions before you're ordering and then when you're interpreting those results. That's all negative and positive predictive values are. Not too complicated, right? Some take homes, again, always ask yourself, what's the probability of X? If it's that intermediate range, likely you need more testing. You're going to ask yourself, have I reached that treatment threshold for disease? If you have, you can probably stop your testing. If you haven't, you need to go further. Third, will any test change my plan for management? So if I order this, is it really going to change the treatment course? If it will, then go ahead and order. If not, again, you can pause and initiate treatment likely. Always weigh the risk benefit of ordering the test, harm versus good. And then lastly, what am I going to do with that negative result? Can I trust it? And what about a positive result? Can I trust it? That's all for today, folks. All of this information is on my medical education blog, npreasoning.com. We have a newsletter that is free weekly with primary care updates and also an upgraded membership. Thank you so much for joining me today, and go ahead and check out my other videos on diagnostic testing principles. Bye now.